Uh-oh, we've got to retrieve a dental implant. This is something you don't want to have to do, but sometimes it happens. And what are the techniques to effectively remove a dental implant? Well, when I have a dental implant that needs to be retrieved, what I like to do is I like to start with the reverse torque. I will put a regular driver in the implant and just see if I can reverse torque it right out of the hole. It's the simplest way to do it. And if you think about it for a second, the vast preponderance of implants you're retrieving are retrieving because they're A, failing, which means they most likely don't have a lot of bone around them, if any at all, or B, they're integrated in bone, but they're not deep enough for you to proceed with an all-on-X case. So the implant was placed as a single unit years ago. Now the patient is moving on to an all-on-X solution, but the implant is too coronal and it has to be retrieved. In those cases, it's quite possible that the implant is fully integrated in bone and you have to retrieve it. So there are two different scenarios. In my practice, what I find is the vast preponderance of dental implants are removed during an all-on-X case. The all-on-X cases, it's just that we haven't had really good metrics for how deep to place implants. In almost every single implant that is placed in the aesthetic zone that's old, that's older than, say, 7 years, has been placed rather shallow, meaning that the implants aren't deep enough, which means that when you go to an all-on-X solution and you're going to go ahead and do hygienic profiling of the bone, the implant's in the way. It's sticking up way too high and it's in the way. So those, and we try so hard every single time to repurpose that implant because the idea is it's integrated, right? It's healthy, it's just in the wrong position, and we try to reutilize those, but it's not often the case that we can. So that's the main type of implant that we retrieve. The other implants that we retrieve are either failures to integrate, which don't require any conversation because they're completely surrounded by soft tissue, okay? So you pick them up with anything, a pair of tissue pickups or hemostats or something, you just pluck it right out of the hole, scrape out all the granulation tissue, irrigate, assess for bony walls, and if you have bony walls, I don't even graft them. Because if you have 5 bony walls, 4 on each surface and 1 on the bottom, it's gonna fill with bone. Just let it fill with bone and come back and place the implant again and tell the patient, don't smoke this time, okay? And then you have some that are failing. So you have implants that have integrated and they have had peri-implantitis, and over time they're failing. That happens occasionally, not as often, I would say, as the all-on-X case for retrieval. But in those cases, they're rather easy to retrieve, right? Because half of them are already out of the bone. The coronal portion is already out of the bone and it's working its way towards the apex. So those are also quite easy to retrieve. Both cases, I'm going to start with putting a regular driver into the implant and trying to retrieve it. In the case where the implant has not a lot of bone around it, usually that works just fine. Sometimes what will happen is I will say, I think I can get this loose, but the driver and torque combo is not strong enough. So what do? I literally grab my ash forceps from my tooth extraction kit. I use an ash forceps. We've talked about this on the show before. The ash forceps is an amazing tool for extracting teeth and implants. Why? Because it conveys a mechanical advantage to the leverage. Okay, so the way it works is if you looked at the ash forceps, it looks like a parrot. The beaks are to the side. They're not in line with the handles. Okay, so that's the ash forceps. And by doing that, you can squeeze in one direction for grip and rotate the entire arm. So the moment arm is very, very large. So I will literally take an ash forceps, put it on the implant, and just try to rotate it out. The only thing that's really integrated, that's holding that implant in, is basically 2 things. 1, the osseointegration, so the bone to the surface, and 2, the flutes. Okay, so the cutting flutes, after you do the cutting and the implant integrates, they form a dovetail. They lock the bone around the implant. So in order to reverse it out, if you can create a reverse torque that's higher than the osseointegration and the cutting flutes, then you can just reverse it out. If not, then I go to my favorite tool, which is my piezo. I use my piezo with an osteotome. An osteotome looks like a sword, okay? And it's thin. And what we do is we set it to about 3/4 power setting with copious irrigation, and we just slide right down along the side of the implant. We go on the mesial, the distal, and on the palatal, but I don't like to go on the facial because there's almost never a case where the facial bone is abundant. So I will go on the other 3 surfaces, but typically not on the facial. It creates a little bit of space. It makes a little space, and it separates the cutting flute bone from the regular bone, which means after I do that, when I go back with my ash forceps, I can just counter rotate it and rotate it right out of the hole. And it's very, very atraumatic. I see people promoting the concept of a Trephine, and Trephines work. They work really well, but that's, in my opinion, kind of the nuclear solution. In other words, a Trephine is a cylinder with teeth on the rim that goes down over your implant, and it cores out the entire implant plus a little bit of bone all the way around, and it makes a rather large defect, okay? So in certain cases, that might be necessary, but I find that oftentimes it's more aggressive than necessary. And if you use a piezo, you can do a much more minimalistic removal and maintain more of the natural bone in that area. So piezo is my first choice. The Trephine solution is one that I have never used. I've never needed to use it. And so there's a third option, which is to use a burr and to go in there and remove the bone around the implant. And that is also an option. And it is one that I've used occasionally. The burr I like to use is a long, straight diamond burr by Brasseler. And I do kind of the same thing. I just go down beside the implant, trying to stay off the implant to the best of my ability and make just a little bit of space between the bone and the implant. And you don't have to remove all of the bone circumferentially around it, because once you get on it with the reverse torque, if you have enough space, it'll just reverse out. But the reason I use that as kind of a last resort is because it's going to create titanium dioxide dust. It's going to create a little bit of residual particles that you're going to leave around the bone. And I'm not particularly keen on that. I don't believe that it has been shown scientifically to cause a problem, because titanium dioxide is inert. Okay, it is the surface of the titanium that we have on all our implants when it goes in the mouth. So it is inert. But if you think about silicone dioxide, which is the product that's on sandpaper, it's hard, right? I mean, you use sandpaper to be abrasive. So if you had particles of titanium dioxide in your soft tissue, you've kind of just made sandpaper, right? So maybe the body would be irritated, and it could create some fiber response to that, and it might not like that so much. So we try to stay away from creating titanium dioxide dust. So in summary, my favorite solution is piezo. Piezo, piezo, piezo. And today's modern piezos, like the ones that are made by W&H, are really powerful. They're not like your dad's piezo, right? Like the piezos that we used years ago, they didn't have the power, guys. Everybody hated them. They loved them for the technology, but we hated them because they just didn't have the torque, right? The punch, the horsepower. We needed more meat, and we didn't have them back then. But today's new modern piezos, they do. In fact, I typically don't put the thing up higher than 75% power. I keep it off the top because it's maybe just a little bit too much. So this has been another episode of Implants Made Simple. I'm the Smile Engineer, helping you re-engineer your practice.